Good morning, dear students. Our lecture today is about part 2 of bleeding in early pregnancy. Ectopic pregnancy means the implantation of the blastocyst anywhere other than in the normal endometrial cavity. Etiology, risk factors for ectopic pregnancy. Mechanical factors. Interfere with the passage of the fertilized ovum. Developmental abnormalities of the tube diverticula, accessory ostia, and hypoplasia. PID destroy the epithelium and form adhesions. Chlamydia, gonorrhea. Peritubal adhesions. Postabortal or puerperal infections, appendicitis, or endometriosis. Tubal surgery. Tubal sterilization, conservative surgery for tubal pregnancy, infertility tubal surgery. Tumors stretching and elongation of the tube fibroid, ovarian, or broad ligament cysts. Decreased tubal motility. IUCD, especially those that contain progesterone. These are more effective at preventing intrauterine pregnancy. Partial tubal block, previous tubal salpingitis. History of infertility. Possible explanation includes tubal factors of infertility. Assisted reproductive techniques. 5% of pregnancies after are ectopic pregnancies. Sites, types. Mainly, fallopian tube. The ampulla accounts for 78%. The isthmus accounts for 12%. The fimbria accounts for 5%. The cornua or interstitial part accounts for 2%. Rarely, other sites. The ovary, primary ovarian pregnancy. The peritoneal cavity, abdominal pregnancy. The pregnancy in a rudimentary horn. The cervix, cervical pregnancy. To be discussed in face-to-face lecture. To be discussed in face-to-face lecture. Pathology of tubal pregnancy. Uterus. At first biplacental and ovarian hormones slightly enlarged and decidual changes. Then after death of the embryo HCG and P decidual shedding and uterine bleeding. Ovaries. One ovary contains corpus luteum of pregnancy. Fallopian tube. The trophoblast to erode into the muscle of the tube, the fertilized ovum becomes bounded. On the outer side by peritoneum and a thin layer of muscle, and on the inner side by tubal mucous membrane and an incomplete sheet of muscle. Tubal pregnancy may end in a dead embryo surrounded by blood clots equals tubal mole which is absorbed. Tube mostly becomes permanently blocked. Little risk to the patient. Intratubal rupture, tubal abortion. The blood will run out into the peritoneal cavity through the abdominal ostium. If the bleeding is slow, it leads to pelvic hematocele which can be absorbed or uncommonly infected. If the bleeding is excessive, it leads to severe intraperitoneal hemorrhage. To be discussed in face-to-face lecture. Extratubal rupture, tubal rupture. Through the peritoneal covering, untum's enteric side, leads to intraperitoneal rupture. Leads to intraperitoneal hemorrhage. The amount of intraperitoneal bleeding is usually greater in tubal rupture than in tubal abortion. Through the floor of the tube, mesenteric side, between the two layers of the broad ligament leads to extraperitoneal rupture, or intraligamentary rupture leads to intraligamentary hematocele. Picture of tubal rupture, extratubal rupture. Abdominal pregnancy very rare. The trophoblast perforates the surface of the tube without causing severe hemorrhage. A communication is made between the intervillous space and the peritoneal cavity. The amniotic sac remains complete and the embryo survive. It either leads to IUFD or continue to term or CFMF. Or neonatal deformities. The classic triad very suggestive of ectopic pregnancy: missed period with pelvic pain and uterine bleed. May clinically appear as one of 5 distinct groups. Undisturbed tubal pregnancy. Symptoms. Pelvic and abdominal pain precedes the bleeding. Due to localized distension of the tube. Plus or minus short period of amenorrhea. No vaginal bleeding, the embryo is still alive. Signs. Abdominal exam, tenderness in one iliac fossa. Vaginal exam. Cervical motion tenderness, jumping sign. Tenderness on one side of the fornices. Paracervical pulsations may be felt. A unilateral tender mass may be felt. Subacutely disturbed tubal pregnancy. Symptoms: pelvic pain and discomfort, dull aching distension of the tube, sharp stabbing repeated in the tubal wall, colicky tubal abortion, vaginal bleeding, plus or minus short period of amenorrhea, plus or minus fainting attacks. Signs: general shock, internal hemorrhage and neurogenic, abdominal tenderness and rigidity in one iliac fossa, pelvic uterus slightly enlarged plus vaginal fornix tender swelling. Subacutely disturbed tubal pregnancy. Symptoms: pelvic pain and discomfort, dull aching distension of the tube, sharp stabbing repeated in the tubal wall, colicky tubal abortion, vaginal bleeding, plus or minus short period of amenorrhea, plus or minus fainting attacks. Signs: general shock, internal hemorrhage and neurogenic, abdominal tenderness and rigidity in one iliac fossa, pelvic uterus slightly enlarged plus vaginal fornix tender swelling. Chronic type with pelvic hematocele. Symptoms: history suggestive of disturbed ectopic amenorrhea and pain and uterine bleeding and fainting attacks. Pressure symptoms on bladder and rectum due to accumulation of blood in Douglas pouch. Signs: general. Vital signs depends on amount of internal hemorrhage. Abdominal. Pelvi-abdominal swelling. Vaginal. Posterior fornix fixed tender swelling. Advanced abdominal pregnancy which either leads to severe internal hemorrhage or rarely. Diagnosis: investigations. Pregnancy tests usually positive. Urine pregnancy tests, not accurate. Serum pregnancy tests HCG level. Normal pregnancy doubles every 2 to 3 days. Ectopic or non-viable intrauterine pregnancy subnormal rise. Ectopic pregnancy is very likely when 1 HCG 6000 mlu/ml and no IUP sac by TAU/S. 2 HCG 2000 mlu/ml and no IUP sac by TVU/S. Ultrasound scanning. Vaginal probe for ultrasound in early pregnancy is more accurate than abdominal ultrasound. Laparoscopy which leads to sure diagnosis but invasive. Choledocentesis. Blood is aspirated from the Douglas pouch through a wide-pored needle. If non-clotting blood is aspirated there is intraperitoneal hemorrhage. Treatment. Approaches. Surgical management. Medical management. Expectant management. Surgical approaches. Laparotomy. Indication: suitable for a hemodynamically unstable patient, with considerable hemorrhage, or if facilities for laparoscopy are not available, experienced staff and instruments. Laparoscopy. Indication: suitable for hemodynamically stable patient. Advantages: less invasive. Disadvantages: controlling hemorrhage is more difficult. Needs special skills. Some patients are not ideal candidates, e.g. obesity. Salpingectomy. Indication: when the size and extent of the ectopic pregnancy are such that preservation of the tube is not possible. With recurrence of ectopic pregnancy in the same tube. Conservative surgery. Indication: if the situation is not acute. When there is only one remaining tube. Therapeutic management. Selection criteria. Ectopic size 3 cm. Tube unruptured and no active bleeding. HCG 3000 mlu/ml. U/S no fetal heart motion. Patient not desiring surgery and agreeing to weekly follow-up visits until the level of serum PHCG is 15 mlu/ml. Protocol. Methotrexate, the commonest medication used. 50 mg/m² of body surface area IM. If HCG does not decline by at least 15% between day 4 and day 7, a second dose is given. If PHCG level does not decline after 3 doses of methotrexate, surgical treatment is indicated. Expectant management. Success rate equals 50%. Those who fail this approach are likely to develop tubal rupture and hemoperitoneum. Considered in women with unknown location of their pregnancy, suspected ectopic pregnancy and low and declining serum hCG levels. Avoided if ultrasonography clearly demonstrates an ectopic pregnancy. Vesicular mole. Hydatidiform mole. It is a benign tumor of the chorionic villi. Risk factors. Previous molar pregnancy. Nutritional and socioeconomic factors: low dietary intake of keratin, vitamin A deficiency. Advanced maternal age, older than 35 years. Geographical Far East. 3 components make up the trophoblast. Cyto. Trophoblast. The cytotrophoblast is a stem cell with high mitotic activity but without hormonal synthesis. Intermediate trophoblast. The intermediate trophoblast has features of the other 2 components and is responsible for endometrial invasion and implantation. Syncytio. Trophoblast. The syncytio trophoblast, which constitutes the villus trophoblast, has low mitotic activity. The syncytio trophoblast is responsible for the synthesis of the beta HCG, and can be identified with immunohistochemical stains. 2 pathological types: complete and partial mole. To be discussed in face-to-face lecture. A hydatidiform mole is an abnormality of fertilization. Complete mole. It is the result of fertilization of a nucleated ovum, has no chromosomes, with a sperm which will duplicate, giving rise to 46 chromosomes of paternal origin only. Partial mole. It is the result of fertilization of an ovum by 2 sperms, so the chromosomal number is 69 chromosomes. Complete HYDATIDIFORM mole. Macroscopic features. Uterus vesicles. The vesicles vary in size from 2 mm to 2 cm. Each vesicle has a fine pedicle with clear watery fluid inside. Ovaries thick lutein ovarian cysts. May reach greater than 6 cm in diameter. Develop in about half the patients with a complete mole. Result from high serum hCG levels. Regress spontaneously within 2 to 4 months after evacuation. Microscopic features. Chorionic villi. Generalized edematous, vesicular, and hydatidiform swelling. Diffuse trophoblastic hyperplasia. Avascular. Lack of identifiable embryonic or fetal tissues. Vesicular mole, large number of vesicles. Hydatidiform mole. Pathological types. Complete HYDATIDIFORM mole. Chromosomal pattern. 46XX karyotype entirely of paternal origin. Haploid sperm, X, fertilizes ovum with absent or inactivated nucleus, then duplicates its own chromosomes. Rarely, dispermic fertilization occurs with consequent loss of maternal set of chromosomes. To be discussed in face-to-face lecture. Partial HYDATIDIFORM mole. Macroscopic features. When a fetus is present, features of triploidy, e.g. XXY, including IUGR and CFMF. Microscopic features. Chorionic villi. Focal hydatidiform swelling, cavitation. Focal trophoblastic hyperplasia. Avascular. Embryonic or fetal tissues identifier. To be discussed in face-to-face lecture. Pathology. There is trophoblastic proliferation, with mitotic activity affecting both syncytial and cytotrophoblastic layers. This causes excessive secretion of HCG, chorionic thyrotrophin, progesterone. Microscopic evaluation shows trophoblastic hyperplasia. There is no vasculature in the chorionic villi, leads to early death and absorption of the embryo. The renal system. Anatomic changes. The primary anatomic change of the renal system is enlargement and dilation of the kidneys and urinary collecting system. The kidneys lengthen by approximately 1 cm during pregnancy. As a result of greater interstitial volume as well as distended renal vasculature. The renal calyces, pelvis, and ureters dilate during pregnancy. Because of mechanical and hormonal factors. Mechanical compression of the ureters occurs as the uterus enlarges and rests on the pelvic brim. The right ureter is usually more dilated than the left, possibly due to dextrorotation of the uterus, and compression from the enlarged right ovarian venous plexus. Progesterone causes relaxation of the smooth muscle of the ureters. Decreases bladder tone, residual volume is increased. As the uterus enlarges as pregnancy progresses, bladder capacity decreases, and there is a tendency towards frequency of micturition. Uniformly edematous, hydropic, villi with dissolution of central stroma, cavitation/cistern. Villous vessels absent, usually. Trophoblastic hyperplasia, circumferential, haphazard, involves CT/ST/IT. Trophoblastic atypia. Symptoms and signs. Usually occur in first 20-24 weeks of gestation. Bleeding. Pain. Toxemia, 25%. Hyperemesis, 25%. Absent fetus, LGA, SGA. Hyperthyroidism, 7%. Passage of tissue with vesicles. Bilateral thecal lutein cysts, 30%. U/S evaluation. Numerous, discrete, anechoic, cystic, spaces within a central area of heterogeneous echotexture. The coexistence of a fetus with a complete hydatidiform mole is uncommon, in contrast to the partial hydatidiform mole, occurring in 1–2% of cases. As a result of dizygotic twinning, thus, the fetus is chromosomally normal. But, fetal survival until term is unlikely because of the maternal complications of the mole itself. U/S diagnosis of a partial molar pregnancy is complex. The finding of multiple cystic spaces in the placenta is suggestive of a partial molar pregnancy. When there is diagnostic doubt about the possibility of a combined molar pregnancy with a viable fetus, then ultrasound examination should be repeated before intervention. The clues for the sonographer in this diagnosis are the presence of a fetus, although usually with severe, but non-specific, abnormalities, in combination with a formed placenta containing numerous cystic spaces. Investigations. U/S, best. Complete mole snowstorm appearance. Partial mole focal cystic spaces in the placental tissues and an increase in the transverse diameter of the gestational sac. No identifiable fetal parts except in partial mole. Bilateral ovarian cysts in 50% of cases. Serum beta-HCG. High serum level of beta-HCG. Plain X-ray of the abdomen, no fetal skeleton. Plain X-ray of the chest for lung metastasis. Treatment. Correct general condition. Evaluate carefully and treat. Anemia. Preeclampsia. Hyperthyroidism. Electrolyte imbalance HEG. Evacuation. Suction curettage. Hysterectomy in toto, old patient 40 years completed her family. Hysterotomy, no place in the updated management of hydatidiform mole. Prophylactic chemotherapy, high-risk patients unreliable for follow-up. Single course of actinomycin D or methotrexate at the time of evacuation. Follow-up. Beta-HCG determination. Weekly until normal for 3 consecutive weeks. Monthly until normal for 6 consecutive months. Contraception. Pregnancy is contraindicated. Why? Patients are encouraged to use effective contraception. COP is used safely. IUCD is not used. At the completion of follow-up, 1 year, pregnancy may be undertaken. D&C. 1 to 2 weeks post-evacuation. When bleeding occurs. Complication. General. Hyperemesis gravidarum. Preeclampsia and eclampsia. Thyrotoxicosis. DIC. Local. Hemorrhage. Infection. Perforation. Malignant change, choriocarcinoma. To be discussed in face-to-face lecture. 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 To be discussed in face-to-face lecture.